Good afternoon. My name is Greg Wahlstrom, and I'd like to welcome you to the Central Illinois chapter of the American College of Healthcare Executives webinar, Physician Hospital Integration in the 21st Century. After this webinar, you will be directed to a short survey, which we will hope you will take the time to fill out. Today's webinar has been awarded 1.5 hours of qualified continuing education credit towards your board certification or recertification through the American College of Healthcare Executives. If any IT problems arise, please visit support.nemeeting.com for further assistance. As we begin the presentation, can you please mute your telephone lines until the question and answer portion of the event? On the left-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. Just as a reminder, this webinar is being recorded. We are happy to announce that there are many attendees who are listening in not only from here in the United States, but other countries such as Canada, India, Italy, Germany, Japan, Europe, Spain, and even the United States Armed Forces naval carrier off the coast of the Atlantic. Today's program, we will be discussing the relationship between hospitals and their medical staff have changed throughout the years from independence to interdependence. The current economic environment and healthcare reform has caused a reassessment of physician-hospital integration models. Healthcare reform promotes an expectation that better coordination of care will improve patient outcomes and community health status. With the movement away from fee-for-service payment and towards provider integration, there is a belief that better coordination of care will slow healthcare costs by reducing duplication of services, hospital readmissions, and inappropriate use of an emergency department. Strategies to integrate physician and hospital interests are necessary components to providing quality of care and achieving economic goals for both parties. The degree of integration varies from minimal to full integration or full employment. This program explores physician-hospital integration models and has panelists address their successes and challenges in the process. The topics we'll cover today are key factors and forces driving physician-hospital integration, physician-hospital integration models, successes and challenges, and employment models. The financial issues regarding physician-hospital integration in view of health reform's new payment models, contracting or legal issues that arise with physician-hospital integration, cultural and leadership considerations for physician-hospital integration, and how to use the framework and maintain improvement in long term. What is the value of a physician-hospital partnership, and what are the incentives for each party, and what are the risks? What are the biggest lessons learned from past attempts and at physician-hospital integration? And also discussing strategies for finding common ground between hospital and medical staff and ways to build and maintain trust. What benefits does the patient receive as a result of physician-hospital integration? And how clinical and financial data can be used to foster effective discussions between physician and hospitals. Discuss the obstacles and barriers to physician-hospital integration in terms of cultural, operational, and/or financial issues. What regulatory and legal issues arise with physician-hospital integration? And what can healthcare executives do to promote effective communication and alignment between physician and the hospital? What models physician integration seems to be showing promise, and what are their outcomes? And also, are physician-hospital integration models sustainable? Today's moderator is Dr. Annette Schnabel, DPT, MBA, FACHE, Chief Operating Officer, Perry Memorial Hospital. Annette joined Perry Memorial Hospital in December 2014 as the Vice President and Chief Operating Officer, where her direct reports include the Director of Physician Clinics and the contracted hospitalist program. Perry Memorial Hospital, as a member of the Illinois Critical Access Hospital Association, is participating in the Illinois Rural Community Care Organization, along with several of the community's independent physicians. Annette started her healthcare career as a physical therapist. She has provided leadership in acute care and critical access hospitals, along with skilled care nursing facilities. As the Director of Rehab and Physician Services at Clay County Hospital, she managed physician practices and rural health clinics, performed physician recruitment, and developed physician specialty clinics. She was the Executive Director of Strategy and Administration at St. Anthony's Memorial Hospital, with responsibility for physician clinical integration, recruitment and relationship, strategic planning, business development, and operational leadership for ancillary services. She led St. Anthony's Physician Clinical Integration Committee, assisted with business case development, and reviewed for physician acquisition decisions, and collaborated with the HSHS Medical Group for their first industry clinic. She led the process for development of organization's hospitalist program and the hospital's physician office electronic medical record assistance program and the hospital to physician electronic medical records interfaces. Annette was a former member of the board of directors and the past chair of the program committees for the American College of Healthcare Executives AM chapter. Our first panelist, Dr. Bryan Becker, MD, MMM, FACP, CPE, Vice President of Clinical Integration and Associate Dean at the University of Chicago Medicine. Dr. Becker is a nephrologist and certified physician executive working to create and deliver value-driven healthcare. He is presently Vice President of Clinical Integration and Associate Dean for Clinical Affairs at the University of Chicago Medicine. He received his AB in English from Dartmouth College and MD from the University of Kansas. He is trained in internal medicine at Duke University Medical Center and nephrology at Vanderbilt University Medical Center. Subsequently, he led the nephrology group at the University of Wisconsin, pulling together all features of kidney disease care in a new venture, Wisconsin Dialysis Incorporated, building a new faculty base and a robust NIH-funded clinical translation research program. He then led all of the clinical performance improvement, safety, and quality activities for the medical specialties, 350 plus physicians in the group practice across academic and community-based sites throughout South Central Wisconsin. Bryan moved to lead the faculty practice plan at the University of Illinois, rising to be the CMO and then the CEO for the University of Illinois Hospital and Clinics. He led transformational efforts to revitalize the organization using change management methodology and across multiple perspectives of a balanced scorecard between transitioning into his present role. Bryan served as president and board member of the National Kidney Foundation, leading national and international screening programs and strategic organizational transition, and advises multiple startups as well as serving as a board member for the Forward Health Group, a population health measurement company, among many other activities. Bryan and his family currently reside in the Chicagoland area. And as we follow with our next presenter, Paula Carynski, MS, RN, NEA-BC, FACHE, President, OSF St. Anthony Medical Center. Paula Carynski joined OSF St. Anthony Medical Center in 1985 and became its president in July 2013. After serving as Vice President of Patient Care Services and Chief Nursing Officer since 1999. Previously, Ms. Carynski served in many capacities at OSF St. Anthony, including Director of Nursing Operations, Director of Regional Heart Institute, and the Director of Neuroscience Institute, and Director of Cardiovascular Services. A graduate of St. Anthony College of Nursing and Rockford College, Ms. Carynski earned a Master's of Science in Nursing Administration from the University of Illinois at Chicago, Her professional development includes participating in the OSF Leadership Academy, where Ms. Carynski was selected as one of the top 10 executives with the OSF system, demonstrating superior leadership characteristics and a capacity for growth. Ms. Carynski is also a member of the American Organization of Nurse Executives and American College of Healthcare Executives. She is board certified in nursing administration by the American Nurses Credentialing Center and has been honored with the Distinguished Nurse Advocate Award by the Illinois Nurses Association District 3. Ms. Carynski is actively involved in Rockford's community activities, serving such organizations as Rosecrans, the Rockford Health Council, American Heart Association, and Transform Rockford. In 2014, Ms. Carynski received the Business Leadership Award from the YWCA of Rockford. And our final panelist, Dr. Tony Avellino, MD, MBA, Chief Executive Officer, OSF Healthcare Neuroscience Service Line, and Illinois Neurological Institute. Tony Avellino, MD, MBA, is presently the CEO at OSF Healthcare Neuroscience Service Line and the Illinois Neurological Institute since August 2014. As a CEO, he is responsible for the strategic, clinical, and operational design, development and delivery and consolidation and integration of neuroscience services across the OSF Healthcare Ministry. Prior to coming to OSF Healthcare, Dr. Avellino served as the director of the University of Washington Medicine Neurosciences Institute and chief of neurological surgery at UW Medical Center. Prior to leading the UW Medicine Neurosciences Institute, Dr. Avellino was the chief of pediatric neurosurgery at Seattle Children's Hospital from 2007 to 2009, and the residency program director at the University of Washington Department of Neurological Surgery from 2005 to 2009. Dr. Avellino obtained his BS from Cornell University, his MD from Columbia University College of Physicians and Surgeons, and his MBA from the George Washington University School of Business. Now I would like to pass the floor over to our moderator, Dr. Annette Schnabel. Annette?
Thank you. First of all, we're going to start with Dr. Bryan Becker, who's going to talk to us about some areas within physician and hospital integration. Dr. Becker.
Annette, thank you very much. And Greg, thank you for the introduction. And welcome to all of you who are viewing or on the call or both. I've been asked to discuss with you some of the key factors that are really very much involved in pushing and linking physicians and hospitals together, and some of the very fundamental pieces around that are beginning to evolve. So what you see on this slide, titled Key Factors and Forces Driving Physician-Hospital Integration, are not just the cartoons of the hospital and the physicians, but the major factors that are new to our healthcare environment, at least in the last several years, that really have prompted both areas of healthcare that are on this slide to think about how they might work better together and what the economies of both scale and efficiency can deliver. First of all, the economic pieces are well known to many of you. And here, for those who are part of our international audience, the United States is experiencing a great deal of impact around fundamental aspects of how to look at not just cost, but the shifts in who's paying for the healthcare per se, in particular the greater role of the federal government. There's also been a resurgence of both interest and emphasis in primary care and recognition that the workforce itself involved with that has to consider how to change to meet the needs of the overall patient population that we care for. In addition, there's a lot of shifts in what we're seeing in how revenue is coming in the door, whether it's changing reimbursement for aspects of testing or how professional fees on the physician side are moving more and more towards risk-based arrangements. In the midst of that, and what's prompted much of this, has been the extensive changes being transitioned into our healthcare system from the Affordable Care Act and the aspects of health reform. And on the hospital side, you can note that there's a lot of emphasis now, not just related to health reform per se, but even in terms of quality management on cost and outcomes, and an emphasis very much on value, with a desire to continue to reduce acute care utilization. Conversely, on the physician side, the advancement of new payment models and the expansion of healthcare coverage for more and more patients has prompted physician practices to look at what the relative benefits are for taking those patients and how to be sustainable if you're a small or modest-sized practice alone, not just in how you're going to look after that group of patients, but how you're going to accommodate aspects such as publicly reported information. And certainly if you're in a specialty practice, what you're doing in conjunction with the primary care base and the shift towards the emphasis in primary care. With those features in mind, a number of different hospital physician integration models have popped up or resurged over the last 2 to 5 years. Some of those are noted on this slide, which has as the various categories the structure, the legal aspects that are important for those structures, how some basic divisional features are part of those structures, what those structures might lead to in terms of differentiation in the marketplace, and finally where each of those structures may have a potential gap or opportunity. I'll just highlight a few aspects from each one. So the medical foundation structure is really what's been developed over time to expand the physician base, and it can link in a formal arrangement somehow with the other entities. Classically, it's been a 501c3, or it can be a 501c6. Ultimately, it's divided primarily around physicians and specialties and the relationships that those entities have with healthcare entities after them. Where it can differentiate because of this structure and the breadth of physicians is in how it's helping support education and research, and academic centers frequently have gone down this route. One of the advantages is that there's a lot of obvious opportunity with that physician breadth to manage risk, and it's also an aspect of how to look and regulate workforce from the physician aspect. What's evolved in many communities is the second aspect in the structural category, the advancement of the physician hospital organization, or the PHO. This represents a joint venture construct between the hospital and one or more physician entities, and it really is divided into the care delivery processes and the administrative services that are supported by the joint venture. Where it can help differentiate is helping look at utilization management and IT infrastructure that the hospital itself has a focus on, and also physician involvement in improving and elevating care. It's got a great advantage when it comes to signal signature contracting and to having an opportunity to share risk, not just across the physician base, but in fact across the care continuum, including the acute care entity. The integrated health organization or integrated delivery system is often tax exempt and not for profit. It usually consists of only one legal entity with multiple subsidiaries, and it can coordinate a lot of activities through internal mechanisms of transfer pricing, which gives it a great leg up in terms of how it approaches managed care contracts. There are also both physician-owned hospitals and hospital ownership of group practices, so one versus the other. They can be set up through various legal constructs, and in particular, in the hospital-owned group practice, you may see an emphasis on how to accommodate a certain proportion of specialty areas that continue to drive business into the hospital setting. Both of them actually look to contract under hospital structures in large part because there's still the ability to obtain the hospital outpatient rate elevation that occurs through HOPD. One of the gaps from the physician-owned hospital piece, which many times are single specialty type hospitals or have been historically in the past, not uniformly, but historically, has been how to best understand hospital operations. And in the context of the hospital ownership group practice, thinking about what you're focused on in terms of productivity and how you're really judging the physician performance. So many different models have been cultivated, not just structurally, but from the standpoint of how to look at different incentive and financial links between the entities just described. Those are noted on a spectrum here on this graph, which goes from left to right with incentives reporting, ultimately leading to full employer contracts. Incentives reporting really is acknowledging what the federal government has asked us to do in terms of PQRS, or Physician Quality Reporting System, as well as meaningful use, and the measures of value-based purchasing that include engagement data. And I've noted CG caps because most hospitals, while familiar with HCAPs, recognize that clinician groups are also going to be measured, and those need to be considered as part of the engagement measurements and ultimately as part of value-based purchasing. Most of you are aware that certain entities have their own self-funded health plans, and there are opportunities within those health plans working with the provider segments to look at shared savings and performance, as well as reducing administrative fees, or what the aggregate per member per month charges or fee is right now, and seeing if it can't be adjusted with great performance over time. Certainly the payer sector has been emphasizing over the last decade plus aspects of pay for performance, or P4P. You have both quality metrics and efficiency, but also the advent of patient-centered medical home models, and even further extension of that into incorporating sets of specialists and other types of services into a medical neighborhood. Hospitals that may have some formal relationship linked together can pursue what's called a hospital efficiency program, where they can legally construct a set of incentive-based agreements around pursuing quality, efficiency, and cost-effectiveness among the various groups of clinicians who are present in their environment. And I've listed some of the parameters there, including reducing complications, enhancing how patients move through those systems, getting to more standardized care, which obviously has direct benefits in terms of patient safety, and thinking about how to manage medications and reduce their complications. The payer segment subsequently has gone well beyond P4P in certain instances to enhance a number of things in their contractual base. And you'll notice that many of those parameters reflect some of the other features that are present. But most significantly, they're allowing organizations, whether they be physician groups, hospitals, PHOs, or delivery systems, to consider how to simultaneously manage both fee-for-service and incentive payments, and work how they're going to determine the best uses of their revenue and use that to help reinvest in their performance. And finally, direct-to-employer contracts, or even some of the other more, I would say, advanced payer contracts, have really pursued how to get to a narrower network of facilities and clinicians who are distinctly involved in the care continuum, both to reduce variation and improve cost, containing those patients and their costs and their outcomes within a system that becomes increasingly and reliant on improved information transfer and improved performance. There are issues that arise in the context of how we manage certain aspects of physician-hospital integration. First of all, entities that have come together can pursue single-signature contracting. That requires a tremendous amount of engagement from various groups and the individual entities that are participating. There's a lot of legal work that goes into ultimately both gaining the signature rights for those entities onto a contract, but I would also suggest, certainly to this audience, a whole lot of work that goes into how to bring those entities along in terms of engagement and buy-in. Many of you are familiar with risk. Risk-based contracts are asking entities to look at and support how they take on care for a larger group of patients with a single base or a single type of payment, and how to distribute that risk both across entities and how to share in that risk so it feels balanced and is designed to achieve greater performance on behalf of the patient. It is important to recognize that entities that come together who may not be formally merged have to acknowledge that there are a significant number of antitrust rules that are designed, for the most part, to prevent organizations from rate setting and achieving less competition rather than more competition in any market. Those have been obviated a bit or reduced by moving to the concept of clinical integration. The Federal Trade Commission has allowed organizations, in particular physician practices or physician hospital organizations, that have come together in the direct pursuit of improving quality and improving performance around efficiency and cost containment, and demonstrating that they're working towards those objectives to not be subject to antitrust violation and antitrust scrutiny. And similarly, because clinical integration is so important, it is a direct underpinning of what you know are accountable care organizations. And finally, because you're merging different types of revenue streams, whether it be fee-for-service and risk, fee-for-service, other types of administrative revenue and risk, these are challenging for organizations that have traditionally been in the situation where they've taken revenue in directly for patient care and used it either to cross-subsidize or reinvest in other areas. The different types of revenue are now requiring different types of financial management as it even rises to the uppermost level of organizations. So you all on this call are in certain high-level positions and influential positions in your organizations where you have to consider what these challenges really mean to what we are doing in healthcare right now. There's a lot of change happening, and I've shown this graph taken from an article, as you can see, that was in the Harvard Business School Press. It's really from a book that was designed ultimately to describe adaptive leadership. And it's asking you really to think about these changes that we're experiencing and the way physicians and hospitals are trying to adjust across these various aspects of either disequilibrium or time. For the most part, just focus on the two yellow lines and the squiggly blue line. And what I want to emphasize for you, and I apologize because it's fuzzy, is that all organizations have a limit of tolerance and have an area where they know they need to learn. And it's in that area where we can be most productive. Right now, I would suggest almost all of us are experiencing not a technical problem, but very much an adaptive challenge that is somewhere along that blue line. And we are moving towards the limit of what we can tolerate, but we are very much beyond our threshold of learning. We are very much getting to the point where we're learning a tremendous number of things. This has been, for us, a very productive time in how to consider physician-hospital integration, the types of relationships that work for our organization, and the types of relationships ultimately that are most productive for patients. And I'll stop there.
Thank you, Dr. Becker. As a reminder to all, you will have the opportunity to ask questions at the end, or you may be able to also type in your questions into the chat area. We'll get to those towards the end as well. In the meantime, I have a couple of questions for Dr. Becker. As you've talked about the different models there are for integration, can you tell us, is there a method to evaluate the different models with a tangible return on investment?
So there are a number of different organizations that are looking to identify what are the best ways to both calculate return on investment, but also which models might be most aligned with that. I think, number one, they're different variables than we had probably considered in the past. When we think about models that extend all the way to accountable care organizations versus models that were just simply physician-owned practices within hospitals. When we look at this, I think the consideration comes down to how is the return on investment from the structure leading to improved efficiency within the organization, the ability to access more lives or more patients, and how does the organization, be it a PHO, a large physician group, or a delivery system, then look at its payer sector constructs and determine what the relative either net benefit it can gain from larger contracts or different contracts versus the efficiencies achieved in taking out some costs in the system. Looking at those various models, scale does seem to be important. So the larger, probably right now, the better. But the different underlying techniques to achieve that, I don't think one can delineate a specific path and may well be organizationally dependent.
Thank you. Another question I have is how is the lagging effect of the incentives that are being by our government? As they've put those in place, they tend to put the incentives on the hospital before they put them on the physician. So with that in consideration, how has the lagging effect of the incentives or penalties application to the physicians impacted clinical integration initiatives?
I think I think the question is really very interesting because the incentive structures, as you noted, that have been put forward, for the most part, are aligned right now with hospital-based performance. I think clinical integration as a logical care improvement process has had a period of now sensitization to the entire medical community. It continues to gain traction, and I think as more and more payment shifts into risk-based arrangements, you will see it gain even more traction, and it will be catching up to what the incentive structures have been that historically have been aligned around hospitals. But I think, and this is me, no great source of other wisdom coming through, I think we're looking at the next 3 to 5 years before there's a full catch-up of those types of incentives that clinical integration is providing and ultimately helping us achieve versus what has been in place for hospitals.
Thank you very much. Next, we're going to move on to our next speaker. Ms. Paula Carynski is going to talk about some different frameworks.
Thank you. Dr. Becker did a great job kind of describing the various integration models that are evolving. And I'm just going to spend a few more minutes talking to you about some additional insights for you to consider when you're going to develop or if you're in the process of developing your own integration strategy. Talked a lot about how this is creating a great deal of change, and managing and leveraging change is hard, regardless of what's going on in your organization. And there is plenty to go around as healthcare reshapes itself. Since creating structure is often the solution to reduce chaos, because that's in some ways what this whole reform and transformation feels like, most hospitals across the country are really seeking an answer to what is the best structure to engage, align, and then more importantly, strengthen the relationships with physicians. I think the desire for engagement and alignment have been a topic of conversation for many years, but these issues have grown really significantly as the demand of healthcare reform and value-driven or value-based intensifies the need for a better coordinated and more cost-effective approach to care delivery. So in response to this new dynamic, it's really apparent that individual physicians, independent medical groups, and hospitals and health systems really are taking a fresh look at the alignment opportunities. It's it's very evident that for the United States healthcare reform to be politically successful, really individually affordable, and nationally sustainable, it must contain the elements of aggressive and serious cost constraints. And this is a challenge not only for hospitals and health systems, but for individual practitioners. And any approach moving forward to sustain cost reductions, healthcare must involve physicians and hospitals. We have to work together, or we'll never be able to achieve these aggressive goals. We all know that hospitalization is the most costly form of care, and conventional wisdom is that physician care decisions drive directly over 80% of the total healthcare cost. And so significant structure changes are needed to accomplish this, and the ultimate framework is to transition from standard thinking to value thinking. You have to ask yourself a new set of questions, which you see on the right hand of this slide, to really change your thinking and how we need to move forward. Really, the key to collaboration is the ability of hospitals and physicians to commit to a shared goal and to develop the capacity to realize those goals. And this really involves establishing trust. Any partnership, any relationship, any structural model that you adopt, it has to be fundamentally entrenched in the trusting relationship between the two. The Illinois Hospital Association really outlined 6 crucial steps to getting started with engaging physicians. The first was really to discover common purpose, such as, and I think if you can frame it as a mutual interest to increase patient outcomes, reduce the hassle and wait times and wasted times that physicians may experience in the organization, and define the opportunities and barriers. You really, I believe you need to create an elevator speech for both parties about the surrounding the market and competitive realities for potential crisis and untapped opportunities. The goal should be to convince really at least 75% of your leaders that the status quo is more dangerous than the unknown, because we are kind of going down a little bit of the unknown path. But ultimately, to achieve optimal effectiveness, leaders should articulate a very clear vision and the direction. And also, that vision needs to be communicated in various learning styles so that people who are expected to contribute toward the new direction and reaching that vision truly understand where we're going. People really do desire to know how the world will look differently if they engage in a partnership or align more closely with you, and what's going to be asked of them. And so they need to be sold on the vision, and they need to be excited about it. The second one is really to reframe your values and your beliefs. And the key here is to make physician partners, not customers. Our old model and our old paradigm was that, physicians are our customers. And we're transitioning now to equal partners. So we need to promote both the system and the individual responsibility for quality. And these are big challenges. These are, but it's very important that you take every opportunity to paint a better tomorrow, and not just not for just some, but for all. The third one is to segment the engagement plan. Once you decide on a strategy, you're going to probably have to use the 80-20 rule. You have to identify and activate champions, because you will have medical staff that will want to participate and lead earlier than others. And once you've identified those champions, you need to educate and inform those leaders, and very early on develop their project management skills. You'll need to continue to work with the laggers so that they're not left too far behind, but not hold off activating any solutions until they come to the table. because otherwise you'll never get it off the ground. The fourth one is really to capitalize on the engaging involvement method. One of the things that you can do to operationalize any engagement model that you end up adopting is to make the right things easy to try and to make the right things easy to do. Because you have to have some quick wins and early wins to keep the momentum going and to help people stay engaged and to trust that the work that they're putting forward is having an impact. You're going to have to show a lot of courage because this is, most of these are major change initiatives, and whether intended to boost quality or improve culture, or in this case, develop a new approach to deliver care and making decisions and having different people at the table to make those decisions, they often only generate lukewarm results if you don't do it correctly, and many fail miserably. So we have to remember that transformation is a process. It's not an event. And it advances through stages that build on each other, and it takes months, if not years. So often in the midst of all of this healthcare reform and the changing economic picture and landscape of providing care, the pressures to accelerate the process or skip stages or take shortcuts really never work. And so you'll have to temper the sense of urgency along with the need for the process to work through the different stages. And then certainly everyone needs to adopt an engaging style. You need to involve physicians from the beginning. You need to choose a message and the messengers carefully and make physician involvement very visible throughout everything you do. And most importantly, you need to communicate candidly and often and value that physician time and your time. People will be driven out of their comfort zones because you're changing traditional structural models that you've had in place for a long time, and so you'll constantly need to articulate the connection between new behaviors and corporate success. So what are the values of a strong relationship? Well, the benefits are endless as listed on this slide. Certainly for the healthcare system, the ability to reduce costs and move your quality scores is paramount. And for physicians, as their quality scores become more publicly transparent and they shift to being paid for value, the need to improve on those scores directly aligns with the hospital's needs. So doctors also become more involved in decision-making, and that ultimately makes their life more efficient and hopefully profitable. And then certainly the ultimate benefit to the patient and the communities that we serve is better coordinated care, better coordination from a time perspective, a quality perspective, and certainly from a cost perspective with an optimal patient experience. I think all of these are really compelling reasons to transform the current care delivery model, and we can only do that with strong partnerships. There are many incentives for aligning. Both parties collaborating with a combined strategy can only gain access to a larger pool of people, enhance the quality, and certainly optimize resource utilization and income if done together. Likewise, there are risks. The new models can be complex, and often there are several models of alignment that need to be adopted because one size does not fit all. It's not uncommon for organizations to be in an employment model, a collaborative model, an ACO, all of these different models that you're trying to coordinate and adapt, and all have their kind of different set of game plans and rules. The commingling, and this is a big one and why we talk a lot about in this presentation about the cultural aspects, the commingling of two different cultures will be challenging and will require a great deal of time and attention. The need to align financial incentives with increased quality from the onset is vitally important. It's too difficult to agree upon those metrics later in the agreement. And another risk that can cause alignment to fail is the intense need to develop physician leaders. We have to take the necessary time for this training. There are several lessons that we have learned from our past and certainly our present. And many of the employment agreements of the 90s, if you will, lacked productivity standards and physician involvement in decision making. We developed these contracts, but we really never engaged them to have a voice. And so physicians commonly in those models received a 3 to 5 year salary guarantee equal to their salary at the time of the purchase, if it was ended up being a purchase practice. And physician employees earned hospital benefits, and there was minimal physician involvement in the organizational decision making, and few work incentives were really tied to their income. And then, of course, human nature prevails in this type of a model where physician productivity started to, it just sank. And then as the trend continued through the 1990s and losses mounted, many hospitals started to dismantle their medical groups and divest themselves of employed physicians. And then for the next decade, of course, the Stark laws and other regulatory limitations sharply curtailed the support hospitals could provide to the practices. And meanwhile, the supply and demand economics encouraged physicians to enter high-demand specialties and practices in communities where competition was limited. So it was no different than today. While dependent on each other, neither the hospital nor the physicians were responsible for one another. This business model had fallen prey to its own set of shortcomings, where the costs continued to rise exponentially and quality gains were kind of stagnated. So we're now in a situation where cost and quality of patient care are unsustainable in those types of models, and that's why these new models are starting to evolve. Healthcare leaders really need to find ways to structure symbiotic relationships with physicians, whether they are employed or independent, in order to successfully navigate the transition from volume-based to value-based. We need to remember those past lessons and not make the same mistakes moving forward. Communication is extremely important in setting really the expectations from the beginning and then following up on a regular basis. Standard business practices really need to be developed prior to any practice acquisition or employment strategy to ensure expectations are clear. And then the hardest part to teach both the hospital leaders and the physician leaders are the stages of change and the pitfalls unique to each stage. It's really interesting that we need to take the time to do that. If both parties understand how to manage change, you can boost your chance of successful transformation. And then certainly moving forward, with each new hire, you want to recruit the right talent. You need to understand what talent is it that we need to recruit and what are those competencies and skill sets. It is far better to determine needs, identify positive attitudes, and recruit physicians than to simply employ the physician who shows up at your door. So I think considering employment needs beyond the physician is key as well. If acquiring a practice, consider who beyond the physician has been important to the practice's success. All too often we concentrate only on the physician and miss securing pertinent support structures within the practice, or mitigate, kind of some of those cultural differences early on that can slow the success of the alignment and the integration in moving forward. So these are all cultural changes, and failure to focus on managing the changes and understanding the culture temperature will result in this, and it'll result in failure. And often failures happen when we don't create a great sense of urgency. We don't create a powerful enough guiding coalition. We don't pull in enough numbers to help us carry the transition through. If we lack the vision and are unable to communicate the vision by a factor of 10, certainly if we don't remove the obstacles to the new vision and get some quick wins, and if we don't systematically plan and create for those short-term wins. The other part we have to remember is not to declare victory too soon and back off of the constant nurturing and mentoring and oversight of the relationships, and not to anchor changes into the culture. It will create failure. So most of what you read about, and we've seen it over and over again, is not to skip on training. The hospitals and physicians are products of two very different institutionalized cultures involving bureaucracy, more in the case of the hospitals, and professional autonomy in the case of physicians. So the differences are more than surface deep, and these differences embrace the nature of employment, the basis of knowledge and view of evidence, and certainly the focus of attention, the time frame of action, and the nature of resources. So you're going to have to make a commitment to physician education, since most physicians don't typically have management and business training. Skills like how to run a meeting simply, or prioritizing time, and dealing with human resource issues. It will not be good enough just to have the physician leaders helping you with the alignment if you don't compensate them adequately and train them for the amount of time that it's going to take. There are a growing number of integrated models, and the dyad model of management is being, kind of one of the more popular management models that's being implemented. And in these models, the management dyad includes a qualified physician paired with a qualified non-physician, leader, manager, director, executive leader, those types of individuals. And the nature behind the model is really to capitalize on leveraging the productivity of the business and clinical talents of the dyad. Medicine is becoming a team sport, and that requires significant behavior changes around the entire healthcare system. Physician leadership, again, the development is key. And because business skills are not taught in medical school, the void has to be filled with rigorous leadership preparation. And it's not uncommon that programs are developing kind of these almost mini MBA programs within the organization to help physicians understand, the development of process improvement plans and some of the fundamental pieces to be successful. So organizing dyads at multiple levels in the organization can accelerate the momentum too, and provide support for the current dyads. They learn and role model together. Looking at pairing an executive leader of a service line with an executive operations leader, pairing a physician practice team leader with a site manager or an operations leader on the hospital side, and then, looking at operation directors within your internal organization or managers with medical directors within the organization. And while clinical decisions may be driven a little more by physician leaders and administrative decisions a little more by administrative leaders, the reality is that the dyad pair are in constant contact. And woven throughout their success of the dyads and the multispecial team is robust data analytics that facilitate good decision making. It also helps accelerate change and support the work of the group. So you do need to develop some internal data analytics support around the dyads and be able to provide them cost, quality, and process data analytics. This is the part, and I'll close with this slide, about the positives of the dyadic management model is what the dyad manages together. And really the emphasis, I want to emphasize that mutual understanding between the dyad of what things are jointly accountable for is necessary. And despite that each of these leaders have separate responsibilities, each owns the overall performance of the unit under them, whether it's a service line, a department, an initiative, a system. And neither is permitted to delegate those responsibilities for the common areas or blame the partner for his or her lack of performance in this regard. The success of each is tied to one another, and the dyad can hold people accountable and foster transparency between the team members. But they have to recognize that ultimately the responsibility for them to manage the culture rests with both of them.
Thank you, Ms. Carynski. I have a couple of questions for you before we move on. You had previously discussed practice acquisitions as well as the goal under healthcare reform to reduce healthcare costs. What consideration is given in clinical integration models to controlling practice-specific expenses?
Well, there's quite a few considerations. I think the best one is to set a cost reduction goal at the onset of any model that you adopt, and put those expectations up front. They can be easily achievable by driving quality outcomes and setting a quality outcome expectation as well. If you have certain gaps in your clinical quality, it should be very transparent to the hospital and the physician side in these relationships. And certainly the expectation that there's an adoption of the evidence-based protocols as a pathway to excellence, so that you can have the groups focus on cost, improving your quality, as well as adopting evidence-based practice. I think as we look at some of the models that are evolving around us and that we're participating in, such as accountable care organization, and the drivers, it is all about the triple aim, and then the care transitions and moving toward population health. So I think clearly articulating what those specific practice expenses are and the need to reduce them are really critical.
Thank you. Another follow-up question. As we look again at the ability to manage the patient across the continuum, have you seen successful methods for attribution of the individual practitioner's impact on the success of the care continuum?
Yes, I'll give you just a local example, if I will, with our cardiovascular service line. They have initiated multiple process improvement initiatives, and they range from small initiatives to large-scale initiatives. And they have actually benchmarked and utilized the financial data. One in specific was in electrophysiology, the discipline of electrophysiology. And that physician leader, individual practitioner, in this case along with his dyad, really looked at how much from a benchmark standpoint, our electrophysiology service was over benchmark. From a financial as well as quality standpoint, we happen to use Ivantage benchmark data in our organization, but they looked at the entire process across the care continuum, and they involved emergency room physicians, the anesthesiologists, family practice physicians, as well as the cardiologists to adopt best practice. And they process improved the anesthesia coverage, the improvement of the room turnaround time. They did an intense staff education and had a continuous dialogue with all of the clinicians on the performance expectations, and upgraded, kind of involved in, our equipment and capital expenditures and upgrading that equipment. And over the course of 6 months, that particular DRG fell off of the overage list and ended up becoming one of the benchmark hospitals for DRGs. So the impact that those individuals had and the influence they had in the organization and turning that particular DRG around was phenomenal.
Thank you. We're going to move on now to Dr. Tony Avellino, and he's going to talk to us about obstacles and barriers to the physician and hospital integration. Dr. Avellino?
Yes. Thank you for asking me to discuss some of my thoughts about physician and hospital integration. As I look at physician and hospital integration, to actually be important, because this integration is key to realizing the hospital's organization strategic goals, such as program development, recruitment of physicians, advanced practice nurses, RNs, the adoption of new technology, as well as the improvement of new facilities. However, there may be some obstacles along the way, and I look at the physician role is really to support and to achieve the triple aim. Well, what I mean by that is how the physician can improve the individual experience of care, improving the health of populations, as well as reducing the per capita cost of care. Because as we move from volume-based healthcare to value-based healthcare, the importance of coordinating care along the care continuum is actually key. But there are some cultural and operational and financial obstacles. Some of the cultural obstacles I see that physicians really must think as we and not I. Because sometimes as physicians, healthcare providers are trained to think as I. It's always I and the particular patient, me and the patient. But however, as healthcare reform evolves and we shift to risk-based contracting, it's really important that physicians think as we to provide quality healthcare. And also, physicians need to think as teams with regards to having the RN involved, the IT, and the community referral partners. There are some operational and financial barriers as well. And some of these operational and financial barriers is one, is as physicians and hospital integration occurs, there has to be buy-in of evidence-based protocols or guidelines. And sometimes having physicians in one specialty to agree on what they are is sometimes very, very tough to do. Some other operation and financial barriers are installing and utilizing hospital EMRs and EHRs, because these are not cheap, but but oftentimes they actually have the seasoned or the older physicians or APNs adopt this new technology is sometimes tough. Third is as evidence-based protocols and guidelines become available, there may be some reduced utilization as well. What I mean by that is there could be some decreasing number of MRIs or CT scans or actually labs. The fourth operation, the issue is sometimes the documentation and coding to capture all the in-hospital billing is not as robust. So what are some regulatory and legal issues that may arise with physician-hospital integration? And I really see that there's 5 legal issues that I would like to discuss. One is the Stark Law and regulations. Secondly is the anti-kickback statute. Third is the civil monetary penalty statute. The fourth is the False Claims Act. And the 5 is there may be some antitrust issues. So with regards to the Stark Law and regulations, this prohibits a physician from making referrals to any inpatient or outpatient hospital services payable by Medicare, which they have a financial relationship. What I mean by that is a physician owns an MRI suite, having that physician refer patients, his patients to actually that is a violation. Secondly, from an anti-kickback statute or the physician self-referral law, this states that it's a criminal offense to offer, pay, solicit, or recover any remuneration to induce services or referrals reimbursable by a federal healthcare program. Third, the civil monetary penalty statute prohibits hospitals from making payments to physicians directly responsible for patient care that might have the effect of decreasing or limiting the services to Medicare or Medicaid. Fourth, with regards to the False Claim Act, it's a violation of the Stark Law as well as the anti-kickback statute. The fifth legal concern is if there's any antitrust issues. What I mean by that is as hospitals and physicians partner and merge, and as it's important that competitors that share contractual sensitive information like price or salary info may lead to price fixing. And so one has to be cognizant of the antitrust issues too. So, there's other regulatory issues that one needs to be aware of too. One is as physicians and hospitals integrate, there may be new billing compliances that the residents or PAs or nurse practitioners or the MDs have to do. We have to be aware of the HIPAA laws, the privacy and security of personal health information. I want to be cognizant of the JCHO, which is the Compliance Safety Performance Monitoring. But physicians and administrators really need to develop a compact whereby the rules of engagement of how to interact with each other and how to manage is actually important. So therefore, there are administrative burdens, like I discussed, as well as regulatory mandates that one has to be aware of. So what can healthcare executives do to promote effective communication and alignment between physicians? One, you have to engage the physicians directly in quality assurance, improvement programs, and outcome initiatives, so all are aligned. The most important person in healthcare is you always have to focus on the particular patient. So really having the focus on that. For example, physicians and hospitals jointly must participate in the development and implementation of standardized policies, including policies regarding evidence-based medicine, service excellence, clinical pathways, IT. Also, physicians and hospitals must jointly develop meaningful data metrics that are relevant, patient-centric, measurable, actionable, transparent, and really easy to understand. Third is there has to be joint participation in the development and implementation of hospital-wide policies and procedures, and participate in hospital committees and networks. Fourth, there has to be joint participation in healthcare reform-related initiatives such as accountable care organizations and value-based purchasing programs. As we move from volume-based to value-based, really having that partnership between physicians and the hospital administration team is actually key. So what models of physician-hospital integration seem to be showing promise, and what are their outcomes? There's no single model, but rather a variety of ways to structure the physician-hospital relationship to support quality, volume, and value metrics. But the goals are, one is to secure the referrals, two is to increase the market share, and then three, negotiation of better rates and contracts with the payers. So what I like to do is go through the four models. One is entire practice acquisition. Secondly is an employment and practice lease. Third is a lease of an entire practice. And fourth is the purchase of ancillaries. So what I will do is go one by one. Entire practice acquisition. This is whereby the hospital or its affiliate purchases all the assets of the physician practice, directly employs all of the physician and non-physician personnel, and assumes all equipment and space leases. And so really the hospital is purchasing everything. Two is if there's an employment and practice lease, whereby the hospital or its affiliate directly employs all of the physicians, but leases all the space, equipment, and non-physician staff. The third is lease of the entire practice, whereby the physicians continue to be the owners or the employees of their existing practice, but they're leased to the hospital or its affiliate. The hospital or its affiliate also leases all the space and equipment and non-physician staff of the practice. The fourth is a hybrid model where you can purchase the ancillaries. What I mean by that, with respect to specialties that provide significant ancillary services such as echocardiograms, the hospital or its affiliate purchases the ancillary business in combination with the employment and practice lease or the lease of the entire practice models. Alternatively, the hospital could only purchase the ancillaries and engage the physician practice to provide medical director services to the hospital-based line. So as you can see that there's four models or a hybrid of them. So are physician-hospital integration models sustainable over time? In this era of healthcare reform, it depends on a whole host of things, such as one, does the physician-hospital integration model support the overall hospital, physician, and health system strategic goals? Two is, does it help physicians prepare for continued shifts in the value-based practice dynamics with new capital dollars for equipment, IT, and so on? Also, third, do these physician-hospital integration models provide access and coverage for a new population of insured patients? Fourth, does it enhance physician compensation? And fifth, does it ensure that the shared goals of the organization and the physicians related to quality, cost, and outcome, are these aligned?
Okay, I have a couple questions for Dr. Avellino then in follow-up. In discussing the culture that's needed under transformation, can you tell us any suggestions what methods are available and effective to promote the team think concept? So you mentioned that we need to get the physician away from thinking about I and thinking about we. Ways to promote that team think concept.
Yes, and so I think as a team think as sort of a brain, as getting people in the room to brainstorm about what are the important ideas, and in order for the brainstorming or team think concept to work, is really to actually have an assigned moderator, but also with that assigned moderator to actually have all the stakeholders for that specific goal or service line in the same room. And it's important that there's common synergy, because what you really want to do is, secondly, is you actually want to identify what are the shared goals, what are the 2 or 3 strategic goals that everyone thinks that should be actually done. But these goals have to be specific, they have to be measurable, they have to be attainable, they have to be relevant, but also they actually have to be time bound. What I mean by that is third is you actually have to set how long is the process to achieve that strategic goal going to take. And then fourth is really having everyone in the same room to begin the conversation, I think is very powerful. And really having people leave their egos at the door and be willing to compromise on specific strategic goals.
And then another question, we're talking about the legal regulations and legal risk. What advice do you have from a hospital-based regulation perspective for someone considering acquiring the physician practices ancillary?
Right. And so, I look at that in 2 ways. One is, does it achieve the hospital organization strategic goals? 2, does it add or expand one's strategic does it really add or expand one strategic service? For example, does it increase the market share in a specific service? Does it increase their referrals? But also, there's a few other things I look at. One is with regards to the potential acquiring physician practice. What are their quality and productivity metrics of their doctors or APNs or support staff? 2 is I oftentimes look at what their plant or facilities are like. Are their equipment new or old? Are their leases good or bad? Third is really I look at from their office management. What is their revenue cycle costs? What are their supply chain costs? What are the technology costs? And really, what are their overhead management costs? Because all this has to be aligned with what the hospital and the acquiring physician strategic shared goals are.
Okay, thank you very much. I'm going to kind of open up some questions to the entire panel for some additional feedback, and then we're going to get to some questions from our audience. Ms. Carynski started to give us an example of a hospital efficiency program or improvement when she discussed the EP program. What I was wondering, if, as far as other examples, how do you set the metrics to measure the success and to value the improvement for shared savings?
Well, this is Paula. One of the things that we have done, and that I think it's wise, is start out with knowing where your gaps are, where your quality gaps are, your cost gaps, and your cultural gaps, and build those then into the metrics to measure success. Some parts of the quick win, you can have it as if you reach this target on an annual basis, then there may be an incentive or a payout. If you want quicker wins, you can set it up so that you analyze it and have metrics quarterly, so that if they achieve the metric in 3 months and then sustain it, there's a quarterly payout and those types of things. I think that's how we've gone about it in the past.
Okay, thank you. This is kind of on the focus of the discussion of the dyadic leadership model. And as we consider your normal process for recruitment and retention versus doing it under the dyad leadership, how is that different? So what considerations do you have to recruit and hire into dyadic leadership model?
Well, often when you're acquiring a practice, for example, if that's the model, you'll very early be able to identify, leaders of that particular practice from the practice side, and be able to have open conversations with them about the role of their leadership, whether it's a dyad model or a medical director model or whatever you adopt, and be very clear of what skills are required and what expectations are. So often when you acquire a practice, sometimes you'll get into a relationship, and we've done this, that maybe there's not a well-groomed or natural leader within the practice group, and you'll have to identify someone and grow them, or maybe hire from outside of a physician leader who is interested in leading transformational change.
Okay. We just have a short time left, so I'm actually going to turn it back to Greg and ask him for some of the questions that came from our audience.
Now we would like to open up the floor for questions and answers from the attendees. On the left-hand side of this webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. The first question is, you mentioned that integration is not taxable, but all practices make profit. Then how is it tax exempted?
I'll take this back. This is Annette. As we look at tax-exempt status, we have to consider what is where does the profit go and what is the profit used for. So in a non-for-profit organization, the profit that does exist is used to be reinvested into the organization for the benefit of the mission for which the organization was initially developed. So as you integrate a practice into that non-for-profit organization, the profits from the practice are integrated back into achieving the mission of the overall organization.
And another general question is, how is the medical education community helping prepare our next generation of physicians for practicing in this evolving environment so they can hit the ground running when they start their evaluating their career options?
Dr. Becker still on the line, or?
I believe we might have lost Dr. Becker. Dr. Avellino, do you have any thoughts or opinions on this question? How is the medical education community helping to prepare our next generation of physicians for practicing in the evolving environment so they can hit the ground running when they start evaluating their career options?
Right. And I think a lot of the residency program directors develop a lecture series throughout the year. And I know that when I was the residency program director, we probably had 3 or 4 lectures each year. Really going through is when one graduates, what are the important things to ask and to look for, such as what type of resources you'll have. Will you have your own advanced practice nurse? Will you have your own RN? What is a reasonable pay? What is a and then really going through other facets of how a particular practice works.
One of the things that we're doing, and they're developing across the country, and this isn't necessarily coming from the medical academic community, but internally in hospitals or through systems, just because we recognize the need to enhance skill sets of physician leaders, is developing physician leadership academies. Taking those physicians, the potential leaders within your organization, and sponsoring them through some didactic and self-learning, self-paced modules, if you will, internally through a formalized leadership academy.
And this question is directed towards Ms. Carynski. How do you get the resource dollars to put in place for the analytics necessary to support the dyad quality registries, financial subspecialties for profit and loss revenue costs?
The resource dollars actually come from a strong case argument of how much money the organization is leaving on the table for loss quality, not being within benchmark of competitors from, a financial cost per DRG. The CFO, our CFO, actually is very involved in that and recognizes and can easily do the return on the investment for investing in the IT infrastructure as well as the data analytic in personnel in order to move, change, and be able to, create that path toward excellence.
And Dr. Avellino, this question was directed to you. Under today's pay-for-performance model, purchasing ancillary services from a practice is difficult as it is often a major income stream for physicians. Until that change, how do we migrate physician practices into the mindset to sell such services?
I think, really, there has to be alignment of what are the specific strategic goals that the physician and the hospital integration as?
And then this is our final question for this afternoon's webinar. I know facilities through the New Jersey Hospital Association that use a large-scale gain-sharing model, all DRGs, all costs, under the Model 1, to very effectively reduce costs by sharing cost savings on inpatient care with their physicians and improved quality as well. Are cultural issues the reason hospitals and systems in Illinois are behind in adopting this game-sharing approach, while states on the East Coast, such as Maryland, Pennsylvania, and New York, have embraced it? Are facilities in Illinois taking the bigger gamble on ACOs?
I wouldn't say that there's one model over the other. I certainly know that ACO, there's a lot of pioneer ACOs and moving in that direction, but we're also involved in a lot of risk-sharing programs, Blue Cross Blue Shield, and that sort of thing. So I don't know if it's a hesitancy or more cumbersome from a legal standpoint in ironing out all the gain-sharing pieces.
Great, thanks for sharing. We would like to especially thank today's webinar moderator, Dr. Annette Schnabel, and panelists Dr. Bryan Becker, Paula Carynski, and Dr. Anthony Avellino for taking the time to share pertinent information about physician-hospital integration in the 21st century and the impact it has on each of our healthcare organizations. And here are some additional resources related to today's webinar. The Central Illinois chapter of ACHE will be holding another face-to-face event on Monday, May 4th, 2015, on the healthcare executive's role in IT decisions, worth 1.5 hours of face-to-face education credit through the American College of Healthcare Executives towards your board certification or recertification. We would also like to thank each and every one of you for taking the time out of your busy day to attend today's webinar. Make sure you log into your ACHE account to record your 1.5 hours of qualified education for today's webinar. And if you have any questions in the interim, please do not hesitate to give me a call or shoot me an email to address any questions that you might have in relation to today's webinar. And that concludes today's webinar. Thank you for joining us.